problems. So it's like a mixed type of etiologies. Both you are losing and you are also not producing. Why are we saying this? Now, I've just mentioned that the body's own way of compensating for blood loss, be it hemolysis or be it blood loss through bleeding, is to step up the production of red blood cells. In this case, what's going to happen is that reticulocytes are going to be released faster than normal into the bloodstream. So typical of patients with an issue of blood loss, you realize that reticulocyte counts are high. That's an indication of the body trying to compensate for blood loss. So you realize that more erythropoietin will be released, the red cell precursors will be stimulated, which are released into the bloodstream. So high levels of reticulocyte is, be it through hemolysis or through bleeding. If you are not producing that one, there is maybe lack of nutrients, which could be iron, folic acid, or whatever, or there is a bone marrow impairment. And therefore, if you have more reticulocytes, on the average, your RBC count is going to be high, your MCV is going to be high. Why is the MCV going to be high? Because you have excess amount of reticulocytes and blood loss. Your MCV is likely going to be high, and your reticulocyte count will be higher. It will be the reticulocyte that will be contributing to the increased MCV. This may be cancelled by the issue of iron deficiency, as an example of microcytic anemia. So you are having both bigger cells and smaller cells mixing, and therefore you are getting that will be contributing to the increased MCV. This may be cancelled by the issue of iron deficiency, as an example of microcytic anemia. So you are having both the bigger cells and smaller cells mixing. The anemia, therefore, you are getting also present as normocytic in nature. Class captain, are we okay?
So please go over it.
That will be contributing to the. So we are saying that MCV, you are having issues with hemolysis. May be cancelled by the issue of iron deficiency, as an example of microcytic anemia. So you are having
where you said when the MCV is high and the reticulocyte is
the anemia,
can you please go over that part again?
So when you are having hemolysis, your body's way to solve the problem is to increase red cell production.
So please go over it.
And therefore, you tend to release high. So we are saying that you are having issues with hemolysis, so you are producing it faster and faster. But reticulocyte issue of not a problem. Talk about this as an example of microcytic anemia. So you are having
where you said when the MCV is high and the reticulocyte is way, can you please go over that part again?
So when you are having, when you are losing blood, your body is delivering more of the reticulocyte to increase red cell production. Because of
please go over it.
And therefore, it will increase your MCV. So we are saying that as I check them, you are having this with them, so you are producing it faster and faster. But reticulocyte issue of you don't have nutrients like iron. About this as an example of
the nature.
So you are having
where you said when the MCV is high,
cells that anemia.
Can you please go over that?
So when you are having, when you are losing blood, your body is delivering more of the reticulocyte to increase red cell production.
Please go
on the other side, it will increase your MCV. So we are saying that as I check them, you are having this with them, so you are on the other side. Reticulocyte issue of So it's affecting production. Don't have limits about the
example.
the nature cells
Sorry.
you are so two
When you
extreme
say when the MCV
cells that
please go over that.
so when you are CG, your body is delivering more because the key etiology is happening and
Please go
on the other side of the increase your anxiety. We are saying that is having this on the other side. So this is one particular side where the anemia is affecting that site. The nature cells you are CG cancer. These are cells that so when you are one other issue, your body is delivering more because bone marrow is happening and
please go
on the other side increase your anxiety. We are saying that this so this is one side where production is affecting that side. The nature cells you are CG cancer. These are cells that one other issue your body is delivering more because bone marrow is happening and
please go
on the other increase your anxiety. We are saying that so this is one side where production is affecting that side. The nature cells you are CG cancer. These are cells that one other issue your body is delivering more because bone marrow is happening and
please go
on the other increase your anxiety. We are saying that chemotherapy. So this is one where production is affecting that side. The nature cells you are CG cancer. These are cells that one other issue your body is delivering more because bone marrow is happening and on the bone marrow is chemotherapy. So this is one where production is affecting that side. The nature cells you are CG cancer. Cells one other issue your body is delivering more so this if it is due to a true low production, then we call it aplastic anemia. If it is all the three cell lines that are down, then it could be only aplastic anemia or myelodysplastic issue. At times, it may not be pancytopenia, but maybe one of the cells will go down and the others will be normal. For example, as it happens when you put some patient on erythropoietin, a situation or a phenomenon called pure red cell aplasia. Pure red cell aplasia. In this situation, those that are exposed to erythropoietin develop antibodies, and the antibodies will exclusively target the red cell lineage, reducing only red cell production, but leaving WBC and platelets to be produced. So you realize that on the FBC panel, white blood cell levels are normal, thrombocytes are normal, but it is only red cells that happens. So the problem or the three cell lines, or it can affect one of them or two of them. Typical example is what normally happens when patients are exposed to erythropoietin. A phenomenon called pure red cell aplasia, where because of the presence of the erythropoietin, the patient see erythropoietin as foreign and therefore mount an inflammatory response, produces antibodies, and the antibodies will destroy the red cell lineage. At the end of the day, only red cell will drop. WBCs, platelets will not be touched. This can also happen. Any of this will be what may occur when you have the reticulocyte index being extremely low, bone marrow problems, any issues under normocytic. These are all introductions. We will tackle them properly when we are done with the introductions. Can we continue? Class capture. Can we continue? So now, the macrocytic anemia. Thankfully, we've done this under the normocytic anemias because we said early stage macrocytic anemias can result as normocytic. Early stage is too early for the bigger cell sizes to predominate. But at this point, we are talking about when the macrocytic anemia is well established, and therefore, on the average, bigger cell sizes are predominating with reduced hemoglobin. It's the same explanation, the methyl malonic acid test and the homocysteine test. If both are high, we can implicate vitamin B12, aka cyanocobalamin. If only homocysteine is high, implicate B9, which is folic acid. These can happen then. And we call it megaloblastic anemia. If in the case of pernicious anemia, then there will be an autoimmune reaction. Antibodies fail. They also produce intrinsic factor that is needed for effective absorption of vitamin B12 from the GIT. So without B12, without intrinsic factor, you are going to have problem with B12 absorption. Almost 90% of your B12 is absorbed via intrinsic factor action. Few amounts, like low amount, 10% or even lower, at times even 1%, will be absorbed through passive diffusion. But a chunk of it needs intrinsic factor for absorption. So when you destroy the source of your intrinsic factor, that is parietal cells, by developing antibodies against parietal cells, or you develop antibodies against the intrinsic factor itself, reaction to occur only for you to destroy the intrinsic factor. Then you are not going to have effective absorption of vitamin B12. What happens? Megaloblastic anemia. This is specifically termed pernicious. And now, if you have other organ problems, hypothyroidism, liver issues. That can also lead to anemias with, on the average, bigger cell sizes. These contribute to the non-megaloblastic macrocytic anemias. Key cause again is alcohol abuse. You take alcohol a lot, chronically. Remember, alcohol has a diuretic effect. Vitamins that are water soluble, you are going to lose them. And metabolites of alcohol like aldehyde dehydrogenase has damaging effect on mitochondrial function and several other cellular functions. So alcohol abuse is one non-megaloblastic macrocytic anemia. To check for the levels of alcohol in the blood, so you do blood alcohol concentration. To confirm, take Encopia. If the guy always take Aquatation, full bottle, chronically, then you always have to check. There are other drugs that can also interfere with DNA synthesis, and for that matter, the metabolism of B12 and or B9, and again contribute to macrocytic anemia. The funny thing is that you again need B12 and B9 to help in the production of DNA precursors. And therefore, if you don't metabolize B12, B9 well, you are not going to produce the precursors for DNA. Every protein containing organ or organelle or structure needs DNA. Red blood cells are no exception, and therefore they are going to be affected. Hello?
Yes. Earlier we were talking about the monocytic anemia. And you were saying that, I don't know whether this is what you said, but the B12 and B9, you said the early stage was monocytic, and then the late stage becomes the macrocytic. Is that what you said? Oh?
Yes. So the late stage, that is when the situation is well established. Then the true nature will occur. Bigger cell sizes than normal.
And then what pathology or abnormality would solely lead to monocytic without it becoming macrocytic in the early stage? Is it just the CKD or?
No, yeah. So those organ problems like CKD, even with that, please, that is all things being equal. You can get the CKD patient with macrocytic anemia. Maybe iron deficiency is also there. So don't take it like straightly jacketed that every CKD patient will by all means come with normocytic anemia. So if you get a case and the type of anemia in the CKD patient is macrocytic, you think the question is wrong. No, in practical terms, things can change. But all things being equal, CKD would always come as normocytic, normochromic anemias. Please, are you okay?
Yes.
Hello. All right. So let's look at drugs that can also contribute to macrocytic anemias. And normally, these drugs, you will see that it's either they are affecting some organ function or they are negatively affecting B12 or B9 metabolism. So you look at methotrexate, you look at cotramoxazole, that is sulfur methoxazole with trimethoprim. If you look at the biochemical pathway of B12 and then folic acid metabolism, you realize that these drugs have negative interactions, and therefore they are negatively affecting DNA precursor production because they interfere with folic acid and or B12 metabolism. So drugs that can cause this, they also have that chance of contributing to macrocytic type of anemia. One interesting thing is that because you are not producing enough precursors for DNA synthesis, DNA is produced within the nucleus. Is that not so? So cell division within the nucleus is going to be impaired. The S phase, cell division, the S phase within the nucleus. We are talking about nutrients that are required for DNA precursor synthesis. And if these are not there, then it means that DNA synthesis is going to be impaired. You need DNA for cell division. And this happens within the nucleus. So it means that within the nucleus, you are not going to have appropriate cell division. It will be impaired. However, the cell growth within the cytoplasm will be normal. For this reason, all the cell lines, be it white blood cells or red blood cells, even the platelet, could be affected. And therefore, one of the cardinal signs that you may see when you have, for example, B12 and or B9 deficiency, that is the typical megaloblastic anemia, because when they are not there or when they are not functioning, you will have issues with DNA synthesis that will affect cell division. You realize that cells, including white blood cells, their nucleus cannot divide well. The S phase of cell division is impaired. And therefore, you realize that the nucleus or the cell in total will be hyper-segmented. So hyper-segmented neutrophils, as an example, is a clear indication of megaloblastic anemia, that is B12 and B9 deficiency. Why? Because DNA synthesis that is needed to aid appropriate cell division is missing. You don't have B12, B9 there. And therefore, the proper cell division within the nucleus is going to be impaired. This, however, will not affect the cytoplasmic division. And this will result as hyper-segmented neutrophils. So you have neutrophils, white blood cells as an example, with at least 5 lobes, 5 segments. If on a peripheral blood smell, you will find MCV being higher, and from the peripheral blood smell, you realize that neutrophils are having more than 5 lobes, then is an indication of lack of B12 and or B9, megaloblastic type of anemia. Why? Because these two are crucial when you are looking at developing precursors for DNA synthesis. And you need these DNA precursors for effective S-phase cell division, which happens within the nucleus. So in the nucleus, you realize that the cells will be hyper-segmented. If it is non-megaloblastic, you realize that these cells are not hyper-segmented, but the MCV is high. Possibly, you can also determine organ-specific problems, like liver issues or thyroid issues. In addition to this, you can adequately
cause the macrocytic anemia.
Yes, so you realize that most of these drugs cited here, if you look at the biochemical pathway of folic acid, dihydrotetrafolate, its metabolism, where B12 also work as a cofactor to help in demethylation towards the production of red cell precursors. You realize that the enzymes that will catalyze the intermediate steps, most of these drugs are antagonists to those enzymes. So, for example, converting ditetrahydrofolate, dihydrofolate to tetrahydrofolate, you realize that the component of cotrimoxazole, that is trimethoprim and sulfamethoxazole, especially trimethoprim, affect that stage, and therefore you cannot reactivate your dihydrofolate. This affects DNA synthesis. Methotrexate will do same. So it's either these drugs are affecting some enzymes upstream or downstream the biochemical pathway of folic acid and B12 metabolism. If that happens, what's going to happen is that the B12 and the folic acid can work, and you are going to have issues with DNA synthesis. If you have issues with DNA synthesis, that is when you produce macrocytes, red cells with bigger sizes than normal. So that is why we are implicating these drugs. When we get to macrocytic anemia proper, we will have to go through the folate metabolic pathway, and your red cells are going to have bigger sizes than normal, macrocytic anemia. That's why we are implicating these drugs. Please, are you okay? Hello? The one who asked the question, please, are you okay? Hello? Before we continue, please, can you confirm if you are okay or not? Please, class captain, can you still hear me? Am I still online?
Yes, sir.
Okay, so maybe she's off. So let's continue when she comes. All right, so now let's briefly look at the hemolytic types of anemia. That one we mentioned G6PD, that is possibly an enzyme problem of red cells. We have another example, hemoglobinopathy, sickle cell disease. And then we have the autoimmune type of red cell lysis, be it warm or be it the cold type. Now, how do you know that somebody is having hemolytic anemias? So there is anemia, HB is low. Then you probe further to find out which one is there. You do your reticulocyte index, and it is greater than 2. If it is greater than 2, then it cannot be a production problem. It can only be a loss problem. Losses, it can only be 2. Either you are bleeding or you are losing the red cells through hemolysis. So if not losses through bleeding, then the loss can only be through red cell breakdown. How do you know that it is hemolysis? There are key markers that can be identified if the anemia is due to loss, as confirmed by the reticulocyte index, and therefore specifically it is due to red cell lysis. Now, your red blood cells contains high levels of an enzyme called lactate dehydrogenase. Red cells contain high levels of lactate.
Looks like you're speeding up.
Okay, all right. So now we have HB being low. Anemia is confirmed. We did the reticulocyte index and it is greater than 2. As discussed earlier, Ri greater than 2 cannot be a production problem. So we are going to close our mind and not going to consider nutrient issues or bone marrow issues. That one is out. The moment reticulocyte index is greater than 2, we know that it is all about losses. If so, then losses, it could be due to either hemolysis or bleeding. So how do we know that the retic index greater than 2% is due to bleeding or due to hemolysis? Now, if it is due to hemolysis, there are markers that could be identified so that we can use that one to confirm if it is due to hemolysis. Now, red cells contains high levels of this enzyme called lactate dehydrogenase. So very simple. When the red cells, they lyse, it means that the lactate dehydrogenase in the red cells are going to be released in high amount into the bloodstream. And when you consider checking the levels of LDH, it is going to be high because they are coming from the red cells that are being hemolyzed. So high levels of LDH could or is one of the parameters that confirms hemolysis called hemoglobin. The hemoglobin is normally processed because it could be harmful. It could be harmful. When it gets to the kidneys, it can cause kidney damage. So your liver would normally work on it and add some water-soluble agent and make it possible to be excreted. So glucuronidase acid, something that behaves just like glucose, will be added. So it will be conjugated. If it is conjugated, then it becomes water-soluble and you can excrete it. But the moment you break down excess red blood cells, note that here we don't have any problem with the liver. The liver is intact. You produce excess hemoglobin, which is further processed, and you produce bilirubin more from the hemoglobin. The excess bilirubin overwhelms the liver's capacity to conjugate, and therefore you have, or you begin to have high levels of unconjugated bilirubin. This is not the case that your liver is sick. Your liver has its own capacity. For example, if it can conjugate 100 micromoles or millimoles of bilirubin within 10 seconds, and you present 1,000, it can't do overjob. It will work on what it can, and the excess will remain unconjugated. If this happens, you realize that the bilirubin that was produced from the released hemoglobin will begin to be deposited in special areas like your sclera. You suffer from jaundice. So jaundice could be a marker of hemolysis. But note that jaundice could be also a marker of liver disease. But the moment you have an intact liver and you still have high levels of bilirubin being manifested as discoloration or yellowish discoloration of the sclera, then it is another marker for hemolysis. Why? Because the hemolysis will result in the release of hemoglobin. And the hemoglobin is processed. One of the end products is bilirubin. If it is within range, it will be conjugated by the liver for excretion. But if hemolysis is too much and you release far excess hemoglobin, that results in extra or high excess levels of bilirubin, then it is going to be unconjugated. You will have most of them that will not be conjugated for excretion. The unconjugated one will discolor your sclera and give you jaundice. So jaundice is a possible marker for hemolysis, but it can also be a marker for liver impairment. Now, the hemoglobin that is released, as I said, can be harmful. If it gets to the kidney, for example, it can destroy the kidney. It can easily cause AKI. That is how come in severe malaria, where you have this malaria parasite, Plasmodium falciparum, extremely destroying red blood cells left, right, center, you have patients presenting with hemoglobinuria, a Coca-Cola-like urine. If you are not lucky at that level, it will cause renal dysfunction, and the patient can also present with AKI. For this reason, God, in his own sense, made sure that a protein that is produced mainly by the liver, called haptoglobin, will always be available to mop up excess hemoglobin released by the hemolyzed red cells. Which means that as hemolysis occurs, you use or you utilize your haptoglobin to mop up the excess hemoglobin being released into the blood. This will help you so that the hemoglobin will not get to the kidney and cause problems, which possibly is going to lead to a reduction in your blood haptoglobin levels. Why? You are using your haptoglobin levels to mop up the excess hemoglobin. And therefore, low levels of haptoglobin is another marker for hemolysis. So high LDH, high levels of unconjugated bilirubin, and now low levels of haptoglobin, the protein that mops excess hemoglobin. And therefore, its
Hi.
concentration. Hello?
Yeah, hello, sir.
Yeah, hello?
Please, can you go over it again? I don't know. The line keep breaking, so I can't hear you properly.
Okay, so let me use this as an example. If you have acidosis, you realize that on the ABG, one typical finding is reduced bicarbonate. Why? Because when you have metabolic acidosis, you utilize your bicarbonate stores to counter the acidosis. So your bicarbonate levels will reduce. Let's come to hemolytic anemia. Once you hemolyze your red blood cells, you release excess amount of hemoglobin. This can be harmful to organs like the kidney. So the liver produces haptoglobin. Its job is to mop up the excess hemoglobin that you have released. So in using the haptoglobin to mop up the hemoglobin, the haptoglobin levels will reduce, and therefore a reduced haptoglobin level could be used as a marker for hemolysis. Why? It's because during hemolysis, hemoglobin is released, and when hemoglobin is released, you utilize your haptoglobin stores to fight or mop up the hemoglobin, resulting in a reduction of your haptoglobin levels. Please, are you okay? So reduced levels of haptoglobin is another marker for hemolysis. Are you okay? The one who asked the question.